Well, the concept about suprachoroidal buckling is utilizing the choroid to treat retinal detachment. Theoretically, we don't need the sclera, as we were all using scleral buckles, we don't need the sclera to close a retinal tear. So now we're just using the choroid to create a choroidal dome to close retinal tears and treat retinal detachment. For that, we're using a suprachoroidal cannula that goes in the suprachoroidal space. It's an atraumatic cannula that is 23 gauge, and it has an expansion at the tip, or an olive tip, so it's atraumatic underneath the choroid in the suprachoroidal space. Then we inject the filler to form a dome that closes the retinal tears. We use the olive tip cannula to treat retinal breaks, as well as to create peripheral retinal supports if we need to create a circumferential support to the retina, like cases of primary retinal detachments with peripheral tears, or supporting the retina, inferior retina, in cases of subsilicon retinal detachment. An ideal patient will be a patient with inferior retinal detachment in a phakic young adult. In these particular patients, it's very difficult to tell these patients to go vitrectomy and sacrifice the lens, or even supporting the inferior retina. Especially with vitrectomy, we have to shave the vitreous base, and that is a part of a difficult approach in young adults. So now this is another option that we can give to the patient, having a suprachoroidal buckle that closes the tear, supports the retina as if he was doing a scleral buckling, but into a more simpler approach, less traumatic. There is no muscle imbalance that happens, no hooking of the muscles during this procedure. Just it is solved from one single sclerotomy that we do this. Usually, if we're doing this case for this technique for the first time, I'll tell whoever is doing it to pick up a patient with normal thickness choroid, normal sclera that has one retinal tear or two retinal tears. Then that makes it easy to approach. All that he has to use is just a chandelier and a microscope, and just open over the tear directly. The most important thing is creating a safe sclerotomy to enter the suprachoroidal space. Once he achieves that, the second step is how does he feel the sensation of the cannula moving in the suprachoroidal space. It has to be slow, pushing toward the sclera, not toward the choroid, and things have to take time to give time to the choroid to yield and to stretch, detaching it all the way. Then in the first case, it has to be slow. So it's always safer than being faster. Once we do this technique in one single tear, and you can actually indent and see the expansion of the choroid once the assistant starts to inject, you get more confidence to start moving side to sides to treat a 2-tear, 3-tear, or even going 180 degree or 3 clock hours from one single sclerotomy site. So having a normal thickness choroid, that's one part. Guiding it into the eye is a second thing. Third thing is getting the confidence of indenting the choroid, because we're all used to indenting the sclera, but this is the first time we'll be indenting the choroidal tissue. So that needs to be slow in the beginning. Take your time and see the expansion. Over-treat or over-expand the buckle usually, so you don't have an under-treated or under-filled choroidal dome in the first patients that you'll be treating. And by time, we can start cutting down the amount of the injected material underneath the choroid, because we're more sure how long it lasts in these particular spaces. So the main benefits of suprachoroidal buckling is we avoid the problems of scleral buckling. We know that buckling is being revived, and we're trying to make it more simple and more safe for people or even fellows to start training this technique. So now we have a simpler approach. You don't have to be doing it with the indirect ophthalmoscope for an hour wearing an ophthalmoscope. Now you can do it with a microscope and a chandelier light. That's all that you need. The second thing is you don't see the problems of putting a buckle around the eye, including muscular imbalance, including doing a periotomy to hook the muscles, including changing the myopic status of the eye or the refraction of the eye by putting a buckle around the eye. There is no more problems to that, because now we're just doing the choroidal approach, not the scleral approach, so we don't change the refracture error of the eye in the future. Also about the circulation, there is one good thing about it is there's no impedance or compromise of the circulation. Like if we're putting a big scleral buckle around the eye, we don't need that in going for a suprachoroidal approach. So theoretically, there is a lot of benefits that you can achieve by approaching retinal detachments through the suprachoroidal space compared to the scleral approach. Suprachoroidal buckles is of special benefit in patients having myopia. Usually these patients have refractive surgery to correct their refractive status and get rid of myopia. When they get retinal detachment, if we go for scleral buckles, they are subjected of having 2 degrees, 3 degrees of myopia back again due to the elongation of the eye and putting a buckle around the eye. So suprachoroidal approach is a very good option in these particular patients because it avoids the myopic changes that happen to these particular patients. There is even no damage that happens to the sclera outside the eye, even if they have thin sclera. And this is a particularly important in patients with very high myopic eyes. They have thin sclera and there's difficulty putting sutures around the eye. But going through this technique, we don't face any problems by creating a buckle through the choroid, not through the sclera and the choroid. So this is a particular case scenario in which suprachoroidal buckles, to me, are very important in dealing with these particular patients.